Hi, my name is Katie Connor. I've been working in PA education for about 10 years now. I'm also an orthopedic surgery PA in Charleston, South Carolina. Today, we're going to talk about the pulmonology unit, and this is part of our 13-part series to help make didactic ear a little bit easier and help you to ace your boards. Let's look at the objectives for this unit. As you can see, there's not as many objectives as there are in some of the other units, but remember that pulmonology is one of the most heavily weighted units when you take your PANCE and PANRE. I want to start out by defining something called consolidation. You will hear this word a lot in this unit, and I want to make sure we have a very clear definition of what consolidation is. Very simply, consolidation is when the areas for gas exchange within the lung are filled with something that is not air. So if we look at our pretend lungs over here, for example, you see all the cross marks here. All of those cross marks are going to represent the areas of gas exchange within the lungs. So consolidation can either be a liquid or a solid. For example, exudate is something that we can see in pneumonia, tuberculosis, or ARDS. Purulent fluid in an abscess. Edema in somebody who has congestive heart failure where that fluid backs up. Blood if you have an injury to the pulmonary artery or the bronchial tree. Solids are not as common. Solids could be something like a tumor or a mass if somebody has cancer. Parasitics, not very common in the United States, but in third world countries, you can have something called a hydatid cyst, which is made up of tapeworms, or ascarids are large roundworms that can form masses within the lung. So that's consolidation. The air spaces are filled with something that is not air. Not consolidation, we're going to look at the other lung here and see that it's something that affects the pleural space, which is the tissue surrounding the area for gas exchange. So you can see the areas for gas exchange are compressed, but they're not actually affected themselves. So you can have effusion, which is a liquid in the pleural space, hemothorax, which is blood within the pleural space, empyema, purulent fluid within the pleural space, pneumothorax, which is air within the pleural space. Fibrosis does affect the airways, but it causes scarring. It doesn't cause them to be filled. So that's not technically consolidation. And then finally, we have atelectasis, which can get a little bit tricky. It's kind of in its own category. In atelectasis, what happens is it deflates the balloon, basically, is what atelectasis is. It's the collapse of small airways, our alveoli. So that is consolidation versus not consolidation. And this is going to be really important when we talk about our physical exam findings for this unit. There are 5 main physical exams that are commonly tested on the board, so you need to be able to use them to help you synthesize and figure out your answer. These are whisper pectoriloquy, bronchophony, egophony, tactile fremitus, and percussion. So let's go through them individually here, and then we're going to see them in a little bit more details in the slide. So this is more of our summary slide. In whisper pectoriloquy, you ask the patient to whisper 1, 2, 3. In whisper pectoriloquy, if you are able to make out 1, 2, 3 in your stethoscope, that's an abnormal finding. And what's happening is that the whispered words are becoming more amplified because there's increased air turbulence at the vocal cords. We see this in things like consolidation and atelectasis. In bronchophony, you're going to ask the patient to say 99 in a normal volume. If you can make out the word 99 in the stethoscope, if that's loud and clear, that's abnormal. It's something that happens in consolidation and atelectasis. What happens is there's reduced sound dispersion that normally occurs in the air because we're listening through some type of fluid or liquid. So the word becomes more loud and clear due to reduced sound dispersion. Egophony, we're going to ask the patient to say E. And E is actually made up of 2 different frequencies, a higher pitched A frequency and a lower pitched E frequency. If we have an abnormal finding, we will only hear that A frequency, which is the higher pitched frequency. That's because the lungs are only going to be transmitting that higher pitched frequency. We would see this in consolidation, atelectasis, and effusion. Tactile fremitus, we're actually touching the patient. So you can either use the back of your hands or use your fingertips. And you're going to ask the patient to say, they could say 99, but they could say laundry, Monday, airplane. It doesn't really matter what they're saying. What you're feeling for is you're feeling for those sound vibrations across the lung fields. What's abnormal is if you have a difference in the sound vibrations from one field to another, if they're fast or if they're slow. Remember that sound is transmitted most quickly through a solid, about medium through a liquid, and slowest in a gas. So if somebody has consolidation, which is a solid, we're going to get increased sound vibrations. If somebody has a liquid or a gas problem, so atelectasis, effusion, emphysema, pneumothorax, it's going to be a slower vibration. And then finally, percussion. We're going to use the little DIP joint on our finger like a mallet to percuss over the lung fields. And you're going to go left to right, so that you're comparing the similar areas. It's normal if you have a uniform percussion across the lung fields. It's abnormal if you have a difference. So if something is dull to percussion, or if something is hyper resonant to percussion, kind of think about your lungs like a drum. And if the drum is filled with liquid or a solid, it's going to be kind of dull. If it's filled with air or too much air, it's going to be very resonant. So let's do each of those in detail now. Let's start off with whisper pectoriloquy. Remember, in this one, we're going to ask the patient to whisper 1, 2, 3. In a normal finding, you will not be able to hear this in the stethoscope. But if the patient has consolidation or atelectasis, this causes increased air turbulence at the vocal cords, so it amplifies that sound. So the patient will whisper 1, 2, 3, and you will actually be able to hear that within the stethoscope. So remember, whisper pectoriloquy is present in consolidation and atelectasis. Next, let's do bronchophony. Remember, we're going to ask the patient to say the word 99. In a normal finding, you'll hear kind of a muffled sound throughout the stethoscope. You won't be able to make out the word 99. But if the patient has consolidation or atelectasis, that will decrease the sound dispersion that normally occurs in gas, and it will make that word sound loud and clear. So instead of hearing a muffled sound within that stethoscope, you will hear very clearly the word 99. So remember that bronchophony is present in patients with consolidation and atelectasis. Next, we have egophony. And remember, in egophony, we're going to ask the patient to say E. In a normal patient, you will hear E within the stethoscope the same way that the patient is saying it. But remember that E is made up of A in the higher pitched and E in the lower pitched. So if somebody has consolidation, atelectasis, or pleural effusion, those liquids and solids will only transmit the higher pitch frequency, which is the A. So you will have positive egophony when you hear the frequency A in the stethoscope rather than E. And that's present in consolidation, atelectasis, and pleural effusion. Next, we have tactile fremitus, where we either use the edges of our hands or our fingertips, and we're going to be feeling the sound vibrations over the lungs. The normal findings, and you can have them say 99, Monday, laundry, airplane, it doesn't really matter, but you're just having them say something as you're feeling over these fields. You are feeling for those sound vibrations. So in a normal patient, they have uniform vibrations throughout their lung fields. In something that is abnormal, it will either be decreased in things like atelectasis, pleural effusion, pneumothorax, or emphysema, because we're feeling through a liquid or a gas. In consolidation, because that's a solid, remember that that vibration is transmitted a little bit faster. So tactile fremitus will be increased in consolidation and decreased in atelectasis, pleural effusion, pneumothorax, and emphysema. Then finally, we have percussion. Remember, we're percussing on those lung fields left to right. And what we should see on a normal finding is that we have uniform fields of percussion, that they should be resonant, not hyperresonant, but resonant. If we have abnormal, we're going to have dullness to percussion. So that would be things like consolidation, atelectasis, or pleural effusion, because that means our drum is filled with a solid or a liquid, and so it's not as resonant. If we have air trapping in things like emphysema or pneumothorax, we will have hyperresonance to percussion. So those are our physical exam findings, and those are really important to be familiar with because it will help you to figure out the answer to that question based on just the physical exam findings alone. Now let's talk about pulmonary function testing. It's important to be familiar with these capacities and volumes. So we're going to start out with tidal volume. That's the normal amount of air going in and out as we're sitting here talking, and that's about 10 cc's per kilogram. Then we have something called the inspiratory reserve volume. This is the maximum amount of inhale above the tidal volume, and that's about 3 liters in a healthy person. Then we have the expiratory reserve volume, and that's the amount of air that you can blow out maximally underneath that tidal volume, and that's about 1 liter. Then we have something called the residual volume, and this is kind of the dead air in the airspace that does not participate in gas exchange. That's about 1 liter. Then we have vital capacity. This is the expiratory reserve plus the inspiratory reserve plus the tidal volume. So I think about this, the vital capacity. It's the vital amount of air that we have to use. Then we have inspiratory capacity, different than inspiratory reserve because it contains the tidal inhalation plus the maximum inhalation. Similarly, we have the functional residual capacity, and this is going to be the residual volume plus the expiratory reserve. That's about 2 liters. Then we have the total lung capacity, and this is about 6 liters. This is everything. Your inspiratory reserve plus your tidal volume plus your expiratory reserve plus your residual volume makes up the total lung capacity. Now let's talk about the DLCO test. This measures carbon monoxide diffusion capacity. And this looks at what is happening across the capillary alveolar membrane. A normal capillary alveolar membrane will have a normal amount of gas exchange. That makes sense. So in things like asthma, bronchitis, and effusion, you have a normal amount of gas exchange because that capillary alveolar membrane is not damaged, it's functional. A damaged capillary alveolar membrane will have a low amount of gas exchange. So let's pretend we have scarring on that area. So in things like emphysema, fibrosis, pulmonary hypertension, and ARDS, acute respiratory distress syndrome, we don't have any of that gas exchange because that capillary alveolar membrane is damaged. So that clarifies that test for us. Next, let's talk about spirometry. And spirometry is a way to measure how much a patient can breathe. And so an FEV1 is a measurement of the forced expiratory volume, how much air they can blow out within 1 second. Then we have the FVC, which is the forced vital capacity. That is the maximum amount of air that can be exhaled after a maximum inhale. And we're going to use these two measurements to help us differentiate diseases that are obstructive versus diseases that are restrictive. So let's look at this chart here real quick. A normal spirometry pattern, we should have a good amount of exhalation, so a good FEV1, and then we should still continue to be able to get some air out of the lungs. And so this is kind of our normal here. In an obstructive disorder, they have a decrease in FEV1, so they can't get as much air out. They will also have a decrease in FEV1 over FVC, and we'll go over these in just 1 second. A total lung capacity, because these people air trap, you will have an increase in the total lung capacity and the residual volume because they trap air within the lungs. And then finally, restrictive. The air really can't get in and it really can't get out. So they'll have a decrease in their FEV1, but their FEV1 over FVC will actually be normal. We'll talk about this in one slide. In restrictive, they have a decrease in total lung capacity. So that can help us differentiate the obstructive versus restrictive, because obstructive, they air trap, they get larger lungs, an increase in total lung capacity. In restrictive, they can't get air in or out, so they have a decrease in total lung capacity. So let's walk through why we see this. For the spirometry patterns, I want you to memorize that obstructive has a decreased FEV1 and a decreased FEV1 over FVC. Restrictive is going to have a decreased FEV1, but the FEV1 over FVC is going to be normal. So let's look at why that is. So we have our pretend lungs here, and we're just going to use easy numbers to work with. So let's say in the normal lung, we have an FEV1 of 10. Again, easy number to work with. Let's say we have an FVC of 20. Remember, that's the maximum exhale after the maximum inhale. So that means that our FEV1 over FVC is 0.5. Okay. Now let's take an obstructive disorder. Remember that they have a decreased FEV1. So we'll just cut the normal in half. Let's say it's 5. Their FVC is about 20. So because remember they air trap. So their FEV1 over FVC is going to be 0.25, decreased from normal. Okay. Now restrictive, remember they can't get air in and they can't get air out. So their FEV1 is going to be decreased just like it is in obstructive, but their FVC is also going to be decreased. So if you remember all the way back into math where they said, if you decreased both the top and bottom of the fraction kind of stays the same. So we see that the FEV1 over FVC, because both of our numbers are decreased, that actually makes the ratio stay normal. So this is why we see those patterns. And it's really important for you to know those because you can quickly help to differentiate if something is obstructive versus restrictive based on looking at the FEV1 and the ratio of FEV1 over FVC. Next, let's do a spirometry interpretation. So if you get this as an exam question, the first thing we want to do is look at that FEV1 over FVC ratio. Okay. If it's low, we know that that has to be an obstructive disorder because we just talked about that. Then we're going to look at the predicted FEV1. This is the amount of FEV1 that should be there based on the patient's age, ethnicity, gender, kind of all of these characteristics that said this is what they should be. Mild is going to be less than 70% of predicted. Moderate is about 60 to 69, severe is 59 to 34, and then very severe is going to be less than 34% predicted. Next, let's say we have an FEV1 over FVC that's normal. That has to be restrictive because of what we talked about. Then look at the predicted FVC. Notice that we're not looking at FEV1 here, we're looking at the FVC. Same kind of characteristics when we are figuring out what percentage it is. So the numbers are very similar, but remember, if it's a restrictive disorder, we're looking at the FVC. If it's obstructive, we're looking at the FEV1. So that's kind of how to interpret those. This is kind of a cheat sheet of the commonly tested X-ray findings. We're going to talk about all of these diseases in details, but this is just a good, real quick, if you see this in the question, you should be thinking about this disorder. If we see infiltrates mentioned, this is commonly going to be pneumonia. Honeycombing is something that we see in fibrosis. Pleural plaques are associated with asbestosis. A pencil thin line is associated with pneumothorax. Tram track sign is usually on CT that we see that, but that will be bronchiectasis. Peribronchial cuffing is going to be bronchitis. An apical mass would be something like tuberculosis or a Pankos tumor. Hilar lymphadenopathy is sarcoidosis. Granulomas, tuberculosis and sarcoidosis. Cavitary lesions or cavitations, tuberculosis, abscess, or cancer. Tiny widespread nodules throughout the lung fields would be something like miliary tuberculosis. And then ground glass or frosted glass appearance would be atelectasis, hyaline membrane disease, or pulmonary fibrosis. And again, we'll go all into details on these, but just remember, if you see those words, that should be keying you into that diagnosis. So let's do obstructive versus restrictive lung disease. And I have a couple mnemonics, of course I do for you. The way that I remember obstructive, it's kind of like the Hotel California. You can check in, but you can never leave. This is an air trapping type of disorder. So if you can remember your ABCs, remember A is the first letter in the alphabet, so we only have one. B is the second letter in the alphabet. We have 2 diseases that are B's, and then we have 3 that are C's. So our A is going to be asthma. B's are going to be bronchiectasis and bronchiolitis, and then our C's are going to be COPD, cystic fibrosis, and cancer. So those are our obstructive diseases. You can get air in, but you can't get it out. In restrictive, I think about restricted area, area 51. You can't get in or you can't get out without clearance. So in restrictive disorder, air can't get in and it can't get out. This one I say, remember your vowels, A, E, I, O, and then U is pneumonia, S. ARDS, effusion, interstitial lung disease, obesity, occupationally related pneumonia, and sarcoidosis. So that's how we're going to keep those straight. Let's start off with our obstructive disorders. And the first one that we'll talk about is going to be asthma. With asthma, this is a reversible inflammatory bronchoconstriction that obstructs exhalation. It's a combination of a multifactorial etiology: fibrosis, hypertrophy of the smooth muscles in the airway, blood vessel dilation, and mucus hypersecretion. Those are all important points. In asthma, the patient commonly has a triad. So asthma, atopic dermatitis, remember they're kind of allergic to their own skin, and then aspirin sensitivity. So 3 A's there. The common history for this is a dry night cough, and the attacks, when they get them, they start with this kind of progressive dyspnea. They develop chest tightness and then altered mental status when they're not able to get enough oxygen. Commonly, the attacks are triggered by cold, exercise, allergies, some type of respiratory infection, beta blockers, and smoking. On physical exam for asthma, a decreased oxygen saturation, wheezing when you're listening to their airfields, accessory muscle breathing. They are struggling to get air in. That's during the attack. Tripod posturing. They're leaning over, trying to get the air in and out. Remember, tripod posturing is never a good sign. And then in people with asthma, they're more likely to get those nasal polyps that we talked about in your HEENT unit. Most commonly, this is associated with premature babies and secondhand smoke exposure. For our diagnostics, this is going to be true for all of our obstructive disorders. So a decreased FEV1, a low FEV1 over FVC during the attack. Remember, this is reversible, so they have normal pulmonary function unless they're headed towards an attack. There's something called a methacholine challenge. This is a test that if you suspect asthma, you can give them methacholine, and this will cause bronchoconstriction only in people who are asthmatics. If you give them a bronchodilator like an albuterol, their FEV1 will increase 12%. That's a diagnostic test. So the methacholine challenge with an FEV1 that increases 12% after a bronchodilator is diagnostic. The patient can also have something called a peak expiratory flow meter. This is something they can monitor at home. And if it looks like it's steadily decreasing, that means they're heading towards an attack. Treatment for this, there's an algorithm for this one. So let's look at the classification. So mild intermittent, mild persistent, moderate persistent, and severe persistent. This is going to be based on their daytime symptoms, their nighttime symptoms. So daytime symptoms that are less than 2 per week and nighttime symptoms that are less than 2 per month, they can use a rescue inhaler or albuterol, a short-acting beta agonist that's PRN as needed. Let's say that they have progressed and now they're considered mild persistent. This is daytime symptoms more than 2 a week, but less than 2 a day. And they have less than 2 nighttime symptoms per month. Then we're going to add an inhaled corticosteroid or an ICS to that SABA. Important counseling point here. If it's a pediatric, you can add a spacer to it because kids have a hard time taking that quick breath after you push down on the inhaler. Also, another important counseling point is after you use that inhaled corticosteroid, you want to rinse out your mouth so that the patient doesn't develop thrush that we talked about in your HEENT unit. Let's say now we've progressed and we're moderate persistent. They're having daily exacerbations and exacerbations greater than 2 per week. They're also having nighttime symptoms more than 1 per week. Then we can add a LABA or a long-acting beta agonist. Severe persistent, they're having daily exacerbations now. They're having nightly exacerbations. Now we can add oral steroids. Oral steroids, we want to keep these as a last line therapy because there are very severe consequences to prolonged oral steroid therapy. Status asthmaticus is something where they are within that asthma attack right at that time, and we can treat them with something called a duoneb and a steroid. We want to settle down that inflammation very quickly. Magnesium or terbutaline, epinephrine, and intubation. We want to control that airway very quickly with the status asthmaticus. Next, we'll talk about bronchiectasis. bronchiectasis is the result of some kind of childhood lung disease that causes permanent bronchodilation. And you can see in this top picture here how that area in the blue, it kind of looks dilated. So permanent bronchodilation that happens as a result of cystic fibrosis, cilia dysmotility syndromes, recurrent Klebsiella or Mycoplasma pneumonia, tuberculosis, pertussis, and influenza. And we don't really see tuberculosis and pertussis anymore because we have vaccines for these, and tuberculosis is very well controlled. We don't see that in the normal population. There are some high-risk populations, but this was very common back in the early 1900s. So you see kind of older patients with bronchiectasis who had a childhood history of pertussis and tuberculosis. On the history, a chronic cough for years, and this is very important, purulent, copious, foul-smelling green sputum. They can collect enough in a coffee cup overnight. So purulent, copious, foul-smelling green sputum. Pleuritic chest pain. When we say the word pleuritic, we mean that as they cough or as they breathe, they have chest pain. Recurrent gram-negative pneumonia history in your childhood is one that you may see in the question for bronchiectasis. So some childhood history of recurrent lung disease. On physical exam, you have something kind of non-specific, crackles and rhonchi, scattered wheezing throughout the lung fields, kind of non-specific here. For the diagnosis, remember it's obstructive, so a decreased FEV1 and a low FEV1 over FVC. On chest CT, you may see something called the tram track sign. Remember, we talked about that in our specifics. Look at the bottom part here. It kind of looks like this open area with a line. So that's a chest CT, you'll see a tram track sign. Also for diagnostics for this, you'd want to get a sputum culture because they usually have some pretty nasty bacteria when they're getting these recurrent infections. So you try to get a sputum culture so that you can get a culture and sensitivity off of that. Treatment for this, chest physiotherapy is where they turn the patient kind of upside down and they work on breaking up those mucus plugs so that the mucus can drain out. Steroid medications can be inhaled for maintenance and then oral if they're having an exacerbation. Expectorants, these are medications that help to draw water into the mucus so that it thins it and you can get it out. So guaifenesin. Short-acting beta agonist, albuterol, can help to open the airways so they can breathe better. When they're having an exacerbation in somebody who has bronchiectasis, you want to rotate those antibiotics so that they don't build up resistance. So Bactrim, macrolides, fluoroquinolones are commonly used. And then if you develop local disease, like you see in this top picture there, you can actually go in and excise that area so they don't continue to get those recurrent infections. Next, we have bronchiolitis and RSV, or respiratory syncytial virus. This is very, very, very common. 95% of children will get this prior to age 2 and 75% get it prior to 12 months old. So think really the first year of life in this one. High risk for this are going to be premature infants, daycare, secondhand smoke, and it's usually seasonal. We see kind of a surge in this during the winter time. In RSV, this is bronchial obstruction and constriction. They also get mucus hypersecretion and atelectasis, or collapse of the small airways. The most common causative agent for this is going to be RSV. So remember, 45% is going to be RSV. Parainfluenza is going to be 30%. So it's a close second, but the point is, it is a second. This can also be caused by influenza, adenovirus, and rhinovirus if they have co-infection with RSV. On the history, about 3 to 5 days of fussiness. Remember, this is a young baby, so fussiness, difficulty with feeding, low fever, congestion. If it's very severe, the child may have apnea and actually stop breathing during episodes. On physical exam, tachypnea, tachycardia. Remember, those are normal responses to decrease oxygen saturation. Cough, rales, wheezing when you're listening to them with the stethoscope. If they have these danger signs, they need to be admitted to the hospital. Grunting, cyanosis, nasal flaring, intercostal retractions. They are in severe respiratory distress and they are trying to breathe. So decreased FEV1 because it's obstructive. Low FEV1 over FVC, again, it's obstructive. Oxygen saturation will be less than about 95% in these patients. And on chest x-ray, you can see the top picture here. They have this kind of perihilar fullness. It kind of looks like just kind of a haziness around the end of those main stem bronchi. We can diagnose this with an RSV nasal swab. Treatment for this is usually supportive. Humidified oxygen, fluids, we don't want them to get dehydrated, so PO or IV, and then nasal suction. If they are having trouble, they had any of those danger signs, they have an oxygen saturation less than 90, and they're less than 3 months old, they need to be in the hospital. And ribavirin can be something that's given if it's very, very severe, but typically this is supportive and close observation. Chronic obstructive pulmonary disease, or COPD. This has a multifactorial etiology. This is emphysema and chronic bronchitis, and the majority is going to be smoking, 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 smoking. 90% of this is caused by smoking. In the kind of rare thing where you might see in the exam question that you have a younger person that has no history of smoking, but they have a family history of lung disease, alpha-1 antitrypsin deficiency can cause COPD in a younger patient without any history of smoking. So alpha-1 antitrypsin. With COPD, they have bronchiectasis kind of at the beginning of this. So they get blebs, which turn into a pneumothorax. Then they also develop bronchomalacia, which is a loss of the normal lung recoil. They develop pulmonary hypertension, and then finally cor pulmonale. Remember, we talked about you smoke with your right and you drink with your left. Remember, cor pulmonale is the heart disease that is caused by smoking and mostly COPD. So bronchiectasis and bronchomalacia leads to pulmonary hypertension, and then cor pulmonale or right-sided heart failure. In COPD, patients will frequently get exacerbations of their COPD, and this is usually caused by some kind of bacterial infection, viruses, or seasonal allergies. On history for this patient, chronic productive cough that's worse in the morning, they got to kind of hock a loogie up, breathlessness, and you want to determine their pack years of smoking. That's important to document in the chart. On physical exam, these are really important. A barrel chest, they get an enlarged chest because they're air trapping. Hyperresonant to percussion, remember we talked about that in the physical exam findings. Distant breath or heart sounds, because you're having to listen through a whole bunch of air to hear the heart. Wheezing, oxygen saturation, a lot of these people exist in the 80s to 90s, and so that's just normally who they are. Pursed lip breaths. They're trying to breathe that way. Ruddy and thin, they're kind of reddish and thin. This is more an emphysema type patient, whereas cyanotic and edematous is more of a chronic bronchitis type of patient. So there's kind of two distinct type of patients, more emphysema, more bronchitis. So think red and thin is more emphysema, blue and edematous is more bronchitis. Typically we see this in smokers over the age of 40, and these symptoms of COPD can start at 10 pack years. The average is about 40, so you really have to try to do some lung damage before you get this. Remember that alpha-1 antitrypsin, that's going to be no smoking history, a younger person under age 50, and typically is Caucasian. Diagnostics, because it's obstructive, decreased FEV1, low FEV1 over FVC. That DLCO test, the diffusion of carbon dioxide test that we talked about, that's going to be lower in the emphysema part of this. On chest x-ray, look at the top picture here. They have hyperinflation. You can see these very enlarged lung fields and a flattening of the diaphragm because that enlarged tissue is pushing all of that diaphragm downwards. And so you see that flat diaphragm in that picture. There's something called the Bode index, BMI obstruction based on their FEV1, dyspnea, after what distance do they have shortness of breath, and exercise tolerance, which is measured using a 6-minute walking test. The Bode index, based on those 4 criteria, help us predict this patient's 5-year survival. So it's just kind of a risk stratification. Smoking cessation is important to prevent the progression of COPD. That can be very difficult with these patients because a lot of times it's 40+ pack years history. Pneumococcal and influenza vaccines are recommended for these patients. The treatment algorithm for this one is kind of flip-flop of what it is in asthma. So both of them start out with a SABA. In asthma, we do an ICS next. In COPD, we do the LABA next. Then we go to the inhaled corticosteroid and then oxygen and steroids if needed. So oxygen is indicated if they run at about less than 88% of oxygen saturation. And a lot of that is insurance driven. So they have to be able to show that based on that 6-minute walk test, they have a decrease in oxygen saturation. If they're having an exacerbation of COPD, we can do a duo-neb, which is albuterol and ipratropium. Antibiotics like fluoroquinolones are commonly used, and then steroid medications to decrease that inflammatory process. Next, we have cystic fibrosis. Cystic fibrosis is an autosomal recessive mutation that causes a decrease in the mucus water content, so it makes it very thick and sticky. They also have a decrease in mucociliary clearance. So they've got this really thick mucus, a decrease in the mucociliary clearance, and increase in sweat chloride. This is a multi-organ disease. It affects the lungs, the pancreas, the liver, the intestines, and the reproductive organs. In cystic fibrosis, the history, meconium ileus, they're not able to pass their first stool. Failure to thrive, pale, oily stools, they cannot absorb fat, chronic coughing, recurrent Pseudomonas pneumonia, kind of a weirdish bacteria, sinusitis, pancreatitis. On physical exam, they are underweight. They may have salty skin because they have that increased sweat chloride, barrel chest because they trap air, wheezing, rectal prolapse, jaundice, and nasal polyps. This is a mostly Caucasian disorder, so 1 in 3,500, and it is usually diagnosed by about 6 months of age, but it can be diagnosed much earlier than that. On our FEV1, it's going to be decreased. Low FEV1 over FVC. Why? Because it's an obstructive disorder. There are genetic tests for this. If you know that the parents are carriers, there is a newborn genetic screening for this. You can also do a sweat chloride test, which will show an increased amount of sweat chloride. On chest x-ray, because it's an obstructive disorder, you will get hyperinflation that worsens the older that they get. On cystic fibrosis, for treatment, postural drainage, we're going to tip them upside down and kind of use chest physiotherapy to help to drain that mucus out of there. Pancreatic enzymes, because they don't produce this, we want to replace these. Vitamins K, A, D, E are fat-soluble vitamins. We want to replace those in this patient. A mucolytic, which helps to break up that mucus. Pulmozyme is an example of that. A SABA, albuterol for that rescue inhaler. Transmembrane conductase regulator. This targets the defective protein and helps to improve lung function. This is a relatively new medication. There's a couple of these: ivacaftor, lumacaftor, tazecaftor, and alexacaftor. So these are newer medications on the market to treat this. Lung transplants, even with the lung transplant, the life expectancy is only 40 years for these patients, because remember, it's not just the lungs that are affected. They have other organs that are affected in this disorder. And then our final obstructive is going to be lung cancer. With lung cancer, the patient is going to present with some kind of, they may have a chronic cough because let's say they're a smoker. So a change in their cough or a worsening in their cough. Pleuritic chest pain, so pain with breathing or pain with coughing. Hemoptysis, remember we've talked about in all of our units, cancer bleeds, so they're going to be coughing up blood. Night sweats are a type of B symptoms or secondary symptoms. Resistant pneumonia, their pneumonia is not getting better despite multiple antibiotics because it's not pneumonia, it's actually cancer. Muscle weakness is a rare kind of syndrome called Eaton-Lambert syndrome, and that's associated with small cell types of lung cancer. Weight loss is a B type of symptom or a secondary symptom. Horner syndrome, this one's important because it's a triad. So you know you're probably going to see this on an exam question. Horner syndrome is when you have an apical pancreas tumor, an upper lobe tumor that compresses the sympathetic trunk. So it causes ptosis, meiosis, and facial anhidrosis on the side of the tumor. So ptosis, meiosis, and anhidrosis of the face on the side. That's a triad. You'll see that on an exam question. Etiology of lung cells: smoking, smoking, smoking. Now, smoking is going to be the #1 cause of lung cancer. Also, chronic exposure to environmental carcinogens can be genetic. It can be metastasis from breast cancer. So let's divide this up into small cell and non-small cell. Small cell is going to be about 20% of lung cancers. This is the most aggressive type of cancer, and it usually presents as a central lesion, so on the center of the lung. This one is interesting because it can secrete ADH, which you remember from endocrine. SIADH is the syndrome of inappropriate ADH secretion. So it can secrete ADH and ACTH, which can cause Cushing's disease. So ADH and ACTH are associated with small cell lung cancers. Non-small cell can be divided up into three types: adenocarcinoma, squamous cell, and large cell. Adenocarcinoma overall is the most common lung cancer. It's about 40% of lung cancers. And this can also be common in non-smokers. Adenocarcinoma presents as a peripheral lesion. Squamous cell is going to be central. So the way that I remember the central lesions is they kind of sound like C. So small cell, squamous cell sounds like central. So the two central lesions kind of sound like central. Squamous cell can also be associated with a hypercalcemia. Large cell is the second peripheral lesion. So adenocarcinoma is the first peripheral lesion. Large cell is going to be the second peripheral lesion, and that makes up about 10% of lung cancers. This is the most common cancer worldwide, and we typically see this over age 65 in a 30+ pack year smoker. Diagnosis for this, it's obstructive. So we're going to have a decreased FEV1, a decreased FEV1 over FVC. We start out by taking an X-ray, and we may see something like the red arrow is pointing to on this X-ray. Then a CT scan, a bronchoscopy plus a biopsy if it's central, or a fine needle aspiration going in from the side if it's peripheral. Those are going to be our diagnostic definitive criteria. So bronchoscopy plus biopsy if it's central, fine needle aspiration if it's peripheral, but that will give us the cellular type. If you see a solitary nodule in a non-smoker, they screen that with a CT scan every 6 years, looking for any type of changing or enlargement. If they've gone every 6 months for 2 years and there's no change, they just say it's a solitary nodule, it is non-cancerous. There is a recommendation now for lung cancer screening. It's called a low-dose CT scan, and this is annually done on somebody who meets a pretty specific set of criteria. So ages 55 to 74, plus a 30-pack year smoker, plus they quit smoking within the last 15 years. That's the criteria on which that is indicated. So pretty specific criteria. Treatment, smoking cessation. That's a very important thing, is that even though you have lung cancer, and I've had somebody say, well, I already had cancer, how bad does it get? Well, you can continue to get other cancers, so smoking cessation. This is considered non-operative if they have an exudative pleural effusion, which we'll talk about, or they have distant metastasis. When we stage this, we stage it with TMN, which stands for tumor size, presence of metastasis, and node involvement, so lymph node involvement. If it's stage 1, it's only lung. And this is going to be resection plus radiation that has about a 75% survival rate. Stage 2 is going to be lung plus the hilar lymph nodes. That's going to be resection, chemotherapy, radiation, and that has about a 50% survival. Stage 3 is when it's in the lungs and the mediastinal nodes. That's going to be chemoradiation. And then stage 4 is lung and distant metastasis, and that's going to be chemotherapy only. So remember those key points with lung cancer, the types, small cell versus non-small cell. Remember, adenocarcinoma is the most common type. Remember Horner syndrome. We talked about ptosis, meiosis, and facial anhydrosis. Those are the most highly tested things about lung cancer. So those were all of our obstructive disorders. Now let's talk about our restrictive disorders. And remember, those were our AEIOUSs. We're going to start out with ARDS, acute respiratory distress syndrome. And I want to pull you over to this picture here first. This is called a whiteout. Those lung fields are completely filled. So that's called a whiteout on X-ray. So acute respiratory distress syndrome is something that happens when we have an increase in the capillary alveolar membrane, and it causes flash pulmonary edema and this cytokine inflammatory storm. And this all happens within about 24 hours. So there is a high rate of mortality, about 40% in these patients. You should be looking for in the question an ICU patient that automatically or that suddenly goes into acute respiratory decline. That's very important. These are usually sick people that get ARDS. So ICU patients, sudden respiratory decline. So acute dyspnea, respiratory distress, and cough on the history. On physical exam, bilateral crackles, cyanosis, tachycardia, fever, and then an abrupt decline in oxygen saturation. So all of these signs of respiratory distress. There are two stages for ARDS. The early stage is when you get this flash pulmonary edema. The neutrophils come in and they damage that alveolar epithelial and surfactant producing cells. So it damages the alveolar epithelial cells and the surfactant producing cells. And this leads to no gas exchange. That's why you see that drop off in the oxygen saturation. Then in the later stages, you get this fibroproliferation and scarring of that membrane. So that increases that difficulty in the gas exchange. The triggers for this, think very sick people, sepsis, massive transfusion, near drowning, burns, chest trauma, pneumonia, pancreatitis, fat embolism and opiate overdose, not as common, but think really sick patient. On chest x-ray, like we talked about in this picture, it is a white out. Arterial blood gas, when we do those measurements, we see hypoxia and hypercapnia. They're trapping that carbon dioxide. On arterial PaO2 divided by the oxygen in the inspired air is going to be less than 300. So PaO2 divided by FiO2 is going to be less than 300. Treatment for this is to give steroids during that early phase when you're having that flash edema, the neutrophil damage. Positive end expiratory pressure or PEEP ventilation with high flow oxygen helps to keep those alveoli open. Again, there is a high rate of mortality for this one because it happens very quickly. They have this massive respiratory distress and they're usually sick patients to begin with, so they don't have good immune function. Next, we have pleural effusion. Remember, this is not consolidation. This is fluid between the pleura and it compresses those airways, compresses the lungs. Pleural effusion is going to present with pleuritic chest pain, so pain with breathing and coughing, dyspnea, trouble breathing, decrease in oxygen saturation, decreased breath sounds because you're listening through liquid, decreased tactile fremitus because you know now you're going through a liquid, so you're going to feel that tactile fremitus be decreased in that area. Dullness to percussion because we're percussing over a liquid. Positive egophony. Remember, we're going to hear that A sound rather than the E sound. And then a pleural rub, which kind of sounds like saran wrap being rubbed together. You have two different types of pleural effusion, transudate and exudate. Exudate is going to be more common. The way that I remember this is transudate, they're just passing through. The lung is fine. Transudate, the lungs are normal, and this is caused by congestive heart failure and cirrhosis. So something else going on in the body that increases the hydrostatic pressure, decreases the oncotic pressure, and that capillary alveolar membrane is intact, but you're having this massive buildup of fluid because of either cirrhosis or congestive heart disease. So transudate, it's just passing through. There's nothing wrong with the lungs. Exudate, exiting. That means that they have diseased lungs. They're going to be exiting the world. It's not super sensitive, but it does help you remember. So exudate, it's an increase in the capillary permeability because the lungs are diseased. So cancer, tuberculosis, and pneumonia are the three most common causes of an exudative pleural effusion. Because this is a restrictive disorder, you can't get air in, you can't get air out. You're going to have a decrease in FEV1, but a normal FEV1 over FVC. On chest x-ray, they're going to have an absence of a costophrenic angle. Remember that area where the diaphragm comes down? All of the fluid will collect in that area. So they'll have no costophrenic angle, and then the meniscus sign where you see that fluid kind of settling out. If you don't see this on x-ray, you can order a CT, which can detect much smaller effusions. A thoracocentesis is when we pull the fluid out of that pleural space. We would send that for a gram stain, a culture, and LDH. LDH is something that it's an enzyme that lives within that bacteria. Light's criteria is very important. In Light's criteria, that helps us separate transudate from exudate. So in Light's criteria, an exudative effusion is going to be something that has greater than 0.5 protein, an LDH of greater than 0.6, and the lung fluid LDH is greater than 2/3 the serum LDH. Those are very important. You will be tested on those. The way that I remember this is that exudate is diseased. It's usually made up of some kind of bacteria. We know bacteria are made of protein. They have LDH in them. And so that's how I remember that. If it's an exudative effusion, you want to identify and treat the specific cause. If it's transudate, we know it's because of congestive heart failure or cirrhosis. So we want to try to dump some of the fluid out of the body to keep it from backing up. So diuretics or nitroglycerin can help to either increase the size of the pipes or get rid of some of the fluid. Therapeutic thoracocentesis, when you go in and draw off that fluid, it allows the lung to expand. So not only are you getting something diagnostic out of it, but it's also therapeutic. A tube thoracotomy, where they put a tube and allow that fluid to continually drain out of the lung. That is something that would not be forever for them, but it is something that can be therapeutic in the setting of that. This is very important. We talked about that Light's criteria, how we differentiate transudate from exudate. So remember, transudate is normal lungs, exudate is diseased lungs. Congestive heart failure and cirrhosis are the most common cause of transudate, whereas cancer, tuberculosis, and pneumonia are the most common causes of exudate. Transudate tends to be clear, exudate is more colored or cloudy. Here's our Light's criteria. In transudate, they have a low protein because it's not bacteria. There's nothing that's in there. In exudate, they have an elevated protein, so protein above 0.5. Transudate, they have a low LDH. Exudate, they have an elevated LDH. Transudate, they don't have cells, so less than 500 nucleated cells. Exudate has more because, again, bacteria are in there. The pH is different too. So your transudate, the pH tends to be greater than 7.45, whereas the exudate tends to be less than 7.45 because amino acids that live in that bacteria. That's how I remember that one. So that is everything for our first part. We've got a lot of other diseases to cover here. So I hope that this was helpful for you, and I hope to see you for part 2. If you're interested in learning more, we have 2 different options. If you'd like just the remainder of the review and a PDF of those slides, then that's a $20 option. If you'd like to really master this unit, there is a practice test and some clinical pearls that you can do in addition to the copy of the slides and the rest of the review here. I just want to show you an example of what the clinical pearls matching exercise is. This is all about repetition, repetition, repetition. So we take the key points about the diseases and you can match the disease. This helps you very quickly be able to identify those key points in the question. We have 2 different levels of testing. We have a didactic level, which is designed to be a moderate level difficulty for answer choices. Anything that you answer incorrectly will be emailed to you so that you can study just the things that you missed, which is a more efficient way of studying. We also have a board level exam. This is 5 answer choices and a much more difficult level of question, so much more challenging. Again, you'll get an email with anything that you answered incorrectly so that you can go back and study that. I want to thank you for watching this. Obviously, this is the legal portion, so don't use any of this for diagnostics. It is intended for educational only. I hope that this was helpful for you. We would appreciate if you would subscribe, and please check out all of our other units that are available. Have a great rest of your day.